I would like to just briefly talk about the American Society of Post-Surgical Pain before we proceed with the presentation today. Our mission is to provide a platform that encourages dialogue in managing post-surgical pain for surgeons, anesthesiologists, pain physicians, emergency physicians, physiatrists, nurse anesthetists, anesthesiologist assistants, advanced practitioners, and ancillary staff. There is no society that brings all these specialties together, and that's what we're trying to do. It was established a couple of years ago, and we are here at this juncture doing webinars, and I'll tell you more about what we offer. We also have ultrasound-guided regional anesthesia workshops that are scheduled this year. There are two of them, one in March and one in September. If you'd like to learn more about it, this is the QR code where you can scan. All the workshops are being held in Tampa, Florida. So a good time to escape your cold. We also are the only society that offers cryoneurolysis in the United States. These workshops are very special for the physicians who are interested in learning about cryoneurolysis, both for post-surgical pain and spasticity. So we have two workshops coming up in June and October in Tampa, Florida again. Last but not the least, we had our first annual conference last year. It was a huge success. We would like to continue this tradition of doing annual conferences where we talk about post-surgical pain. Our second annual scientific meeting on post-surgical pain is scheduled to be on December 5th and 6th in Tampa, Florida. The registration is live. So if you would like to learn more, please go to postsurgicalpain.org. Here's the QR code to get to your website as well. Now, these are the conflicts of interest I have to declare. Today's agenda is we will briefly touch base on ultrasound basics. There is anesthesiologists, ER physicians, pain physicians, as the specialties that we are addressing today. We'll talk about in-plane techniques, out-of-plane techniques, and mixed plane. A lot of the docs and providers who are currently doing nerve blocks, primarily, as we know, do in-plane techniques. Some of them do out-of-plane, but it's uncommon. We'll talk about the evidence that supports use of out-of-plane. We'll talk about different nerve blocks which you can apply in your own practice. The art of sonography, they always mention the ART, but I try to emphasize on the fact that tilt is important, so is pressure. So things are more superficial for you and more crisper when you perform these nerve blocks. Probe orientation, as you know, you apply pressure, you can align the probe. Rotation and tilting, these are just depiction. Now, which probe to use? Well, depending on the exam you're performing, a lot of the nerve blocks we perform are done using a high frequency or linear probe. The frequency is usually mentioned on the probe. In these cases, these two probes. If you have a deeper block or you're doing a spinal epidural, you might want to use a low frequency probe. Why? Because the frequency is inversely proportional to wavelength. So a shallow block, you need a high frequency probe. We'll briefly touch base on the screen that you look at on ultrasound every day. There is a exam mode, which is usually a nerve mode because we're doing nerve examinations. There's breast mode, vascular mode, so you can change the modes. The ultrasound machine optimizes your examination to the mode you chose. That's very important to choose. Gain is just the brightness on the screen, and depth is always marked on the right side of the screen in centimeters. Here's 1, 2, 3. Just the terminology again, refreshing for people who don't use ultrasound or not facile using them. Anechoic, where structures appear black, like the blood, any bone, air, and lung. Hypoechoic, where it's gray on the screen, not too white. It's white on the screen, it's hyperechoic. Periosteum and nerves can appear hyperechoic. So this is the image that depicts different approaches we'll be talking about. So we all know about the in-plane approach. A lot of the videos out there, a lot of the trainings that occurs is done in-plane. We talk about mixed plane, which is a hybrid between in and out of plane. This is the out of plane approach, where you're looking at the adductor canal block being performed in different ways, not just one way. Just a depiction of a video here of a simple phantom where you would pass a needle in plane, looking at the shaft, the tip of the needle. So short axis and long axis. So we tried this long axis. I'm going to go short axis now, where you'll be passing the needle in the middle of the screen, but you can see the tip of the needle as well. Now, what is the science behind it? Initially, when nerve blocks were being done, they were all being done in plane. Then studies started coming out in the last 12 to 15 years when they looked at comparing out-of-plane and in-plane approaches. This is the study where Schwenk et al. Looked at interscaling catheters being performed out-of-plane versus in-plane. What they found was there was no increase in the number of complications. It was an acceptable alternative in situations where in-plane is difficult. Let's be very clear. A lot of the people who do these nerve blocks, including myself, will have difficulties performing the nerve blocks since the study says it's a good alternative, why not use it, right? So if you have difficulty finding your needle or doing a procedure, a needle procedure or a nerve block in plane, you could switch to out of plane. Why is it difficult to find your needle? Well, you have a 1 millimeter beam that is trying to line up with a 1 millimeter needle. So obviously it requires a little bit of finesse and practice, and sometimes you never get it. There was another study of 2017. They looked at popliteal nerve blocks performed out of plane. What they found was actually out of plane was faster, it was more effective, and it was safer. We'll dwell deep into those things when we come to the sciatic nerve blocks. So out of plane apparently is faster, safer, and easier. So why should not we be adapting and using it more often? So why out of plane is a question I always get. I try to make it really simple as why not? How do we do our central venous, line insertions in the internal jugular? They are not in plane. They're almost always out of plane. We do have lung, we have carotid artery, and the vessel itself, and we go out of plane. How do we place the IV catheters? We always place them out of plane. How do you do your spinals and epidurals if you're an anesthesiologist? We all do them out of plane blind. So why you'd suddenly have to worry about a small nerve and change your way of doing it in plane and struggle in doing the nerve block? So we're trying to change that, and we've been teaching workshops for the last 8 years, and that's what we achieved for more than 1,000 participants. Now, what blocks can you do out of plane, right? Almost all, except there's a few blocks we would not do out of plane. Why? Because supraclavicular brachial plexus, a very high chance of having pneumothorax. So you don't want to blow the lung. Same thing with intercostal nerve blocks, high chance of pneumothorax. So you just want to be very careful doing them out of plane. So I would say preferably you do in plane. Stellate ganglion blocks also should be done in plane. There's some of the nerve blocks we'll talk about further as we go down this presentation as to when to use in plane, because we have to be safe. Pediatrics, lack of real estate, right? So we use an in-plane approach. So what is it? If you compare out of plane and in plane, there's a steep learning curve when it comes to in-plane nerve blocks. And that discourages a lot of people who would like to learn, but struggle finding the needle. Out of plane, it's a reasonably easy learning curve. There's a long needle path as it goes along the long axis of the probe. There's a short needle path out of plane. So I'm doing less tissue destruction or needle passes. Visualizing needle is pretty good. What you visualize out of plane is tissue displacement. It's very important to know that. In plane is slower, out of plane is faster. Would you like to be slow, or would you like to be fast and do it right? Upper extremity. So we'll be showing you a lot of videos today. So it's not just a talk, but actually showing you proof that these can be done easily, safely, and in a real fast way. So these are the upper extremity blocks. Here's an example of an out of plane approach. The only thing that you're worried about in external jugular, here's a case of a person with 2 external jugular veins. Here's a depiction of how the needle would go. You can go either in the front of the C5, C6 or in the back. It's just in the groove, so you're never touching the nerve. Here's the scanning technique. We always start in the supraclavicular area, brachial plexus, the scanning cephalad as we're trying to find these anterior middle scalene muscles form with the interscalene groove in between C5, C6, C7. Now, things that are not taught is you have an interscalene nerve block you're trying to do, you're scanning up, and you will see a large transcervical artery. So if I pause this video at this level and say, how do you want to approach this? If I come in plane, I will come lateral to medial, I will hit the non-compressible transverse cervical artery. If I go out of plane, I'll still hit it. So what we did in that case is we scanned a little more cephalad wherein the transverse cervical artery was completely out and we could do it out of plane. Here's a simple out of plane interscaling. So here's, you see C5, C6. My needle's coming. It's only about 1 centimeter deep. I'm going between 5 and 6. So how do I know where my needle is? Well, you see the tissue displacement again. I don't have to sell it. It just shows itself. The endpoint of a nerve block is not seeing the tip of the needle. The endpoint of a nerve block is seeing local anesthetic around the nerve target. In this case here, I'm injecting, I'm watching. Do I see the tip of the needle? Do I know where the tip is? I haven't put needle more than 1 centimeter, so I know I'm not too deep, and the medicine seems to be spreading in the right areas. So let's see another example. Scalene muscles, brachial plexus, interscalene groove. So you can either come in the front or the back. So needles being pushed. Here's the tissue displacement. It's very important to see the tissue displacement. I'm actually moving the needle between 5 and 6. You don't have to do it, but I'm just showing you that it is really clear where your needle is, and the endpoint of a nerve block is seeing the medicine around the nerve. Now, why do I don't want to do an in-plane approach? Well, there is hemidiaphragmatic paresis, which we all know. There is a chance of long thoracic and dorsal scapular nerve injury, which occurs if you're doing an in-plane interscaling. So why would I want to risk that? This is how often you would encounter dorsal scapular and long thoracic. So about 62% of the time and 21.4%. So why would I want to take a chance when I can just do a simple out of plane, quick, easy nerve block? And you will see one of these bodybuilders show up. Do you really want to do an in-plane approach interscalene block on this particular gentleman when they have a trap selected? It is technically impossible to do. So you're literally struggling when the nerve block can be done through the skin out of plane. So choice is yours. Suprascapular nerve is an important nerve to your shoulder. This is not the supraclavicular brachial plexus, the suprascapular nerve, which is from the brachial plexus, supplies 70% of the shoulder. There are two approaches. We'll talk about both. The posterior approach, which ER docs, pain docs use it routinely. You as an anesthesiologist, if you're an anesthesiologist, feel free to use it. We're looking for the trapezius, supraspinatus, and the suprascapular notch where the nerve is. So here's the scanning technique. You have scapula with scanning a little medial. We find the suprascapular notch, and here's the artery pulsing. Let's do a video of this as well. So here's the approaches where you can come in plane, where you can see the entire needle in the long axis, or you can come short axis. That way you can know how deep you can go. Here's an out of plane approach for the suprascapular nerve block using the posterior approach. Patient sitting up. I'm just dropping the needle. At the end of the day, is the medicine around the nerve, not the tip of the needle. So let's compare two in-plane and out-of-plane approaches. So we have an in-plane approach and out-of-plane approach. Two different patients side by side. Since it's a deeper block, I can see the tip here. You can see tissue displacement on the right side of the screen. You can see the needle here as well. But once you hit the bone, you know here we have on the left the medicine spreading. We're going to watch on the out-of-plane approach, see how the medicine spreads. The approach really doesn't matter as long as you're skilled with one or the other or both. So I'm giving you a side-to-side comparison of an in and out-of-plane approach. The anterior suprascapular approach avoids the phrenic nerve. This is the suprascapular nerve under the omohyoid. Here's the scalenes. Here's the phrenic nerve going over. So anterior suprascapular is equivalent to your interscalene and non-inferior. Here's the omohyoid and a little suprascapular nerve under the omohyoid. Here's the scanning technique for the anterior suprascapular. Here's the omohyoid. Here's the little dot. I'm tracing it back into the brachial plexus to see the C5, C6. I'll trace it out, and you will see a little dot under the omohyoid, but you're very close to this supraclavicular area. It's subclavian artery. Here's an out-of-plane approach. So it's hard to see. This is the omohyoid, where target is your nerve here. Again, subclavian artery, the rib, first rib. Our goal is to put about 3 to 5 cc around the suprascapular nerve, and you'll get an anterior suprascapular nerve block done. So here's the medicine spreading in the area around the nerve. Very simple out-of-plane approach. I'm only going about 1 centimeter under the skin. Again, very safe. You have this first rib as your safety net. Intraclavicular brachial plexus, again, an important place to place your catheters. Obviously difficult in morbidly obese and bodybuilders. So here's the little child we had to do infraclavicular brachial plexus catheter, artery, vein, the brachial plexus cords, medial, posterior, and lateral, pec major and minor. Here's his actual video of this kid. The needle already has entered. We're trying to go posterior. That's where you want to be, the needle tip. I'm trying to inject and see where it is. So it's right posterior to the artery, as you can see. We actually left catheter in this child. Here's the picture of the child. We left the infraclavicular catheter. He had a firework injury where all his fingers were lost, and he used to get debridements every other day. So it was a lot of pain. I said, well, we actually replaced the catheter again. So a very well functioning catheter, very fast to do. Why would I do infraclavicular approach doing in-plane if I have a clavicle right here and it's difficult to insert? I will insert the needle right next to the shoulder. Axillary brachial plexus, we avoid the lung, very safe. Here's the patient who had a motor vehicle accident, had an olecranon fracture, needs an axillary brachial plexus block. We can't do a supraclavicular because the collar isn't there. She has multiple teeth which are loose, so we can't intubate her. So we did the axillary nerve block, put her to sleep, and not really put her to sleep, but just gave a little sedation so she's still with us, and did the procedure. So axillary nerve block, as you know, the axillary artery, all the nerves around, the muscle cutaneous. Now, why would there's two approaches as we talked about. I can do out-of-plane approach where I drop the needle and start injecting, literally drop under the skin and you start injecting. Or you can struggle like I did on this case. I can see the needle tip, I can see the artery, I can see the nerve. Guess what? Now I can't see the needle tip, so I'm going to tilt the probe. Now I can't see the artery, I cannot see the brachial plexus. Oh, I can't see the tip again. Let me tilt again. Now I can only see the needle, but the nerve is now visible. This is dangerous zone. If I can avoid this dangerous zone and go back to the first image and say, hey, why would I do this if I can just drop a needle and never move my probe, tilt the probe, and just move my needle around the nerve to get it? I'm struggling here. Let's see. I can see the shaft a little bit, artery, and let me find the tip. Oh, guess what? The artery and the nerve disappeared. Am I in the safe zone? I don't know. I think these are the nerves. We're going to just try to inject. Again, this is what you would see when you're doing an in-plane approach, a struggle between the needle tip, the target anatomy, which is the nerve. Ulnar nerve, very easily found next to the ulnar artery. So here's an ulnar nerve block, out of plane. I'm using a 27 gauge needle. Here's the nerve. You can see the tissue displacement on the needle. And you don't know where you are, give a cc of medicine and see where you see the medicine spread. That seems like an easy block. It wasn't difficult. Now, chest wall blocks. We always talk about a lot of chest wall blocks. The anatomical basis is there are many nerve blocks that have been described. You have an intercostal nerve, which comes off the ventral rami. The dorsal rami goes off here. And depending on where you are, the lateral cutaneous branches and the anterior cutaneous branches, different nerve blocks have been described, as you know. Now, PEC1 blocks, the indications of these, if you're doing a subpectoral implant, it's a good block. For a subglandular implant, it's not applicable. Also, pectoral nerves are from the brachial plexus, and if somebody has an AC joint pain after shoulder surgery, you would do a PEC1 block targeting the lateral pectoral nerve, as the AC joint is innervated by the lateral pectoral nerve. Here's the pec major and minor. Here's an out-of-plane approach. Again, you could come here, come in, or come out the plane. So pec major, minor, our goal is to get here. We're about 1 centimeter to 2 centimeters deep. I'm very far from critical structures. I don't even see the pleura. So I don't think I would put the patient at higher risk by doing an out-of-plane approach. You zipper open the fascial plane, and you got a lot of medial pectoral nerves anesthetized. So a lot of times the PEC1 blocks are taught wherein the probe is placed under the clavicle vertically and a longitudinal way. But my suggestion would be try to use the transverse position of this probe wherein you're placing the probe under the clavicle. Again, we're doing an in-plane. You can do out-of-plane as well because the pleura is very far. So I could come in-plane or out-of-plane, but I'm just showing you should consider changing your probe position because most people are taught a PEC1 block is done with the probe being perpendicular in the infraclavicular area, not parallel to the clavicle, but perpendicular. So abdominal wall blocks, again, we see bigger and bigger patients. It's difficult to identify the needle in plane and becomes a real challenge in doing a simple nerve block. So subcostal tap block, here's a patient who had an open splenectomy. This is post-surgical. We just finished a nerve block. Good indication for your open colis, open splenectomy. You will see a rectus muscle and the transverse abdominis, and your goal is to place the anesthetic there. Here's the video of the out-of-plane approach. We're at the bow tie here with the recti on the side, linea alba, rectus, bow tie appearance. So we would scan lateral. Here's the rectus abdominis, and we start seeing a small little muscle, which is the transverse abdominis. Our goal is to go here. So I'm only about 3.5 centimeters from the skin. I'm just going to drop the needle. So as you can see, I'm dropping the needle and there's tissue displacement. I'm moving it around. Everybody can appreciate where my needle is. And where am I now? Well, just give a CC of either saline if you start off. Here we start off with saline, then we switch to the local anesthetic because I don't like to waste the local anesthetic when it comes to abdominal wall blocks. So we're switching from saline now into local anesthetic. So there's a pause. Now the expansion of the fascial plane continues. Rectus sheath block, a very important block to know and learn, and very good for your X-laps, ventral hernia repairs. So here's the rectus muscle, posterior rectus sheath. You just medicines posterior to it. Here's the rectus muscle, all fat. We have anterior rectus, posterior rectus sheath, gap it already exists. We're close to about 3.5 to 4 centimeters. So let's watch how the out-of-plane rectus sheath block works. I'm just dropping the needle. You can all see where it is. Tissue displacement. I'm going to give a CC of the saline. Still in the muscle. We're going to go a little more deeper. Now it looks like we're in a good plane in dissecting the fascial plane there. So we gave the saline. I'm going to switch over to the local anesthetic of choice and then start expanding the space. There's the expansion. So we're switching, takes a few seconds. Now tap block, everybody does these, they love it, but sometimes it becomes a real difficult challenge because you can't see the needle properly. You don't know if you're in the right plane. So we make it really easy. You have external oblique, internal oblique, transverse abdominis. You're trying to come between internal oblique and transverse abdominis, layer between the plane between the second and third muscle here. Most often you'll see this and say, what is my target? Here's the external oblique, internal oblique, transverse abdominis. So we have to go here. You can see the ilioinguinal, iliohypogastric nerves as a hyperechoic structure as well. I'm just going to drop the needle. It's about 3 centimeters. So you'll see how the tissue displacement works. Everybody can see where the needle is. You can struggle in trying to find the needle or just finish the job and move on to the next one. Process is the same. You need to see the local anesthetic spread in the target zone. I don't care if you see the tip of the needle or you don't see the tip of the needle. Lower extremity blocks. Again, we can do femoral nerve blocks, pangs, all these we'll talk about. Here's fascia lata, fascia iliaca. You have femoral nerve, femoral artery, iliacus muscle. Just the aberration of vascular stent appears this way. Femoral nerve is here. So why would I do out-of-plane? Well, it just depends on my mood that day. I would just choose to do out-of-plane if I feel like, or else I can do in-plane where it's very easy to do in-plane femoral nerve blocks. Here's an out-of-plane approach. Here's the artery, nerve, and the iliacus. So we're just going to play that, how it looks like. So I would not go into the meat of the nerve. I would just go on the lateral aspect of it. So we're avoiding the needle to nerve contact as much as possible. So that's very important to make sure so here actually, I thought this was the nerve. And then finally, once the medicine starts spreading, we actually see the nerve here, lateral and posterior to it. So my needle's up here, nerve is here. There was no needle to nerve contact. Very important, right? No intraneural injections. Pericapsular nerve group block or a PENG block. Good for your hip fractures, arthroplasty, hip arthroscopy. Make sure you do a lower volume because higher volumes would get the femoral nerve and then they would have quad weakness. Now, this is where you target the articular branches of the femoral and the accessory obturated nerve. It's pretty much like a deep femoral nerve block. You're just going posterior to the psoas tendon, which is hyperechoic here. The probe is placed in a very similar fashion as your femoral nerve be. Now, would I do out of plane? I prefer not to do out of plane. Again, I'm a guy who does both in plane and out of plane. This you don't want to do out of plane because if I'm coming out of plane, I would hit the psoas tendon of somebody's pristine psoas tendon and potentially tear or damage. So in that case, since we have to go posterior to the psoas tendon, I would say this is a block. I would not do out of plane. I would stick to in-plane approach. Here's a depiction of PENG block being done in plane. Just emphasizing that it's not all about doing out of plane. It's when to do and when not to do out of plane. Like I would not want to do out of plane, so that could potentially target the psoas tendon and damage it. Here's an in-plane approach to the PENG block. Here's the medicine that's spreading. Saphenous nerve block. Again, it's a sensory nerve branch. It's a terminal sensory branch of the femoral nerve, as you know. Great for your knee replacements, knee surgeries. You see a boat-shaped sartorius muscle, vastus medialis, and adductors. So here's an out of plane. Again, I have target, which is, sorry, the artery goes sartorius. Our goal is to just come in posterior to the sartorius muscle. So here's the tissue displacement. Here's my needle, and I'm done in less than 10 seconds. Again, I can try to find my needle, track the needle, get there, but it's up to you what you do. You know, as I also always mention when I teach, it's your patient, your license. You decide what to do and how to do it. I like to do the safest, easiest, more reproducible way than a difficult way. Let's say we started way off. You can literally move the needle wherever you want to. One thing that doesn't move is your nerve image. I can move my needle where I want, but if I'm doing an in-plane approach, I'm always tilting the probe to find the needle, and I lose the anatomical structure I'm looking for and targeting. It becomes an unsafe block. It takes longer. It's unsafe. So same image as I showed before, they can be approached in a mixed plane approach, in-plane, out-of-plane approach. Whatever you feel that day. IPAC. Now, IPAC is a very good block for your posterior knee pain. It's a block that where you put the local anesthetic between the popliteal vessels and the posterior knee capsule, knee joint, in between those two. So good distribution in the posterior aspect, as you can see. So here's an in-plane approach. Patient's lateral decubitus. I'm just showing you both. So target is to go between the artery and then the condyles. So I'm just digging into the patient's joint. Here's the needle coming in. Needle tip being visualized. Ending up in the target zone. Spread of medicine in the target zone. Let's do out of plane. Again, you know, I could be between the artery and the bone somewhere here. So this is an out of plane IPAC would look like. Here's I see a lot of the tissue displacement we talked about when we're doing an out of plane approach. So we don't know where the needle is now. So guess what? That's obviously a technical problem we will face. But okay, well, I know I'm not piercing the artery. I want to see local anesthetic spread. There's the spread slowly coming into view. Not very precise in that case. Anyway, so I think The game changer for outer plane would be when you're doing the sciatic nerve blocks in the popliteal fossa. I've had multiple patients who came to me because they have had common peripheral nerve injury after an anesthesia nerve block. Guess what? They were done, either the patient was asleep or they were all done in plane where they were struggling to find the nerve or to put the medicine around the common peripheral tibial components. If I'm coming out of plane, you would never touch the nerve. The needle will never touch the nerve. It's the safest way of approaching a sciatic nerve in the popliteal crease. I've seen patients being supine and everything's upside down. Preferred position would be lateral decubitus or prone because it's easier. Why would you make your life difficult when doing these nerve blocks? Try not to do that. So here's the patient lateral decubitus. I'm placing my probe and the needle's right next to the probe. Here's a sciatic nerve. It's 1 centimeter under the skin. So why would I want to struggle doing in-plane approach when I can just place the probe, finish the block in less than 30 seconds? Here's the tibial nerve, common peroneal artery so far. I'm just coming in between. You can see the tissue displacement. You know where the needle is. I know where the needle is. The endpoint is to see a local anesthetic spread around the sciatic nerve. So we're not being asked to do a lot of complex procedure. It's a very simple thing to do. People make it a big deal of nerve block, saying, I can't find the needle. It's taking me 7 minutes, 10 minutes. No, it's a 30-second block if you're doing it right. People just want to make it look like it's a difficult thing to do a peripheral nerve block. It's actually not. Here's a nice spread of medicine around the two components, and I haven't touched the nerve. There is zero chance of nerve injury because I never touched the nerve. And I'm very fast at doing that. Here's a full video of a patient lateral decubitus. Here's the knee of the outside and inside part. I'm literally taking a 5 centimeter needle, placing right next to the probe. You can see the tissue displacement. I'm not going too deep, very superficial.
Keep going.
So if you're not doing outer plane sciatic, you're missing out on the fun, to be honest. I've had so much fun doing this outer plane within 30 seconds versus people like struggling up and down, patient supine, the screen is upside down, trying to find the needle and the tip. Here's a spread. It's less than 30 seconds of a video, real time. Here's more samples of how you can change your practice, how you can do outer plane. Here's a tibial component. I'm just coming in between. I'm not doing any harm to the nerve. Very simple nerve block when it is simple, when nobody teaches you how to do outer plane. They will just make sure you always find the tip and make you nervous, make yourselves nervous. Take longer time to do a simple nerve block when it's literally skin pierce in between the nerves, inject, get the medicine around the nerves. I see a good spread. I'm sure it'll be a very successful block there. Here's another one, so I can keep showing you that it's okay to do an outer plane approach. Here's a tibial common peroneal component. I look like I went close to the common peroneal. Well, let me move the needle. Here, actually, you can see the tip of the needle. Easily visualized. Again, I'm seeing a good spread around the common peroneal, but not much in the tibial. I can always come back here. You can see the tip of the needle, and then anesthetize the tibial as well. Here's the problems with in-plane. This is, I'm sure you've seen. I'm coming in, I can see the shaft, the tip disappears. I can see the nerve, tip appears, shaft appears, tip disappears. I don't know if I'm hurting the nerve at this point. But luckily, we have a space between those two, and I may be able to inject between those. But I can see the shaft, tip is not available. So why do we do this dance when you can just drop the needle between those two and get the nerve block faster and safer and easier? The choice is yours. We always have a choice every day. Deep peroneal nerve block, just above the ankle. Here's the anterior tibial artery. We're going lateral. Here's the needle. Tibial nerve block. This is just above the ankle. Very great, a good block for your bunionectomies, anything on the bottom of the foot or the plantar surface of the foot. Posterior tibial artery, here's the nerve. I'm coming out of plane. I start injecting. Here's the tip of the needle. You can see the tip of the needle out of plane as well. But again, it's such a superficial block. There's not much real estate for me to put the in-plane approach. I'll just do an out-of-plane approach, excuse me. You can see the tip. I'm just playing now that you can play with the needle out of plane. Just pushing it inside the fluid. So last but not the least, we have, just remind us about the American Cryoneurolysis Workshop if you're interested in perioperative cryoneurolysis or post-surgical pain management using cryoneurolysis. One is in June, one is in October. So please scan the QR code to learn more about it. And please consider attending the post-surgical pain annual scientific meeting, which is the second one this year. First one was last year, second one's this year. The dates are December 5th and 6th, so you have a lot of time to plan ahead. Tampa is a great place to visit. We're at the La Meridian Hotel, so a wonderful 4-star hotel for you guys. The presentation's pretty much finished. We would like to see if you have any questions. Please put them on the chat box, and then I will answer any questions. I don't see any questions being asked, Nick, so we'll see if there's any questions coming up. There's a question here, Q&A. Thanks for the enjoyed your tutelage again, Mark Rosenthal. Thank you, Mark. Very kind of you to join. Any resources you can recommend? So ASPSP YouTube link is there, which the American Society for Post-Surgical Pain has a YouTube. And also, if you're a member of the American Society of Post-Surgical Pain, you'll access about 200 videos, close to 100 images, which will talk about a lot of the out-of-plane approaches. Our workshops are tailored to teach you out-of-plane and in-plane approaches. We emphasize more on the out-of-plane because that's not taught anywhere else. So just look up, Nick can forward the link to the YouTube channel, which will have a lot of this. Let's see any of the questions, comments. Can you do out-of-plane supine with upside-down picture? So the question is, for ankle fracture patients in cast, sometimes it's hard to turn them. Can you do out-of-plane? Very good question, very pertinent to the topic. Absolutely, yes. This was from, sorry, I'm trying to see. This is from Amir Hanna. What you have to do is rotate the patient's hip. You would do an internal rotation of the hip. So that way, I'm going to show you here on my leg. So I would just rotate the hip. That opens at the back of the thigh, so back of the popliteal fossa. So it's very easy to just rotate the thigh, and then you can see the back of the knee. So you can do the out-of-plane approach, popliteal fossa, sciatic nerve block. I see there is broadcast allpostsurgicalpain.org is the society website. I'm trying to see if there's any more questions, Nick.
I think we're caught up.
All right, that sounds good. If you have any questions, again, this webinar is recorded. So obviously these resources will be available to you in a few days. Nick will send you a link to the recorded webinar so you can see all the videos I presented. You're welcome to come to our workshops, which are very robust and a small group, not a huge group, where we do about 10 to 15 attendees at a time. So we give enough time for them to scan all day long until your hands fall off. So yes. Any closing comments, Nick?
No, just looking forward to our next webinar. We'll get that information out as quick as possible. We'll also distribute the link to this recording, and yeah, definitely check out the conference in December.
Thank you all. Have a good night. Appreciate you guys showing up.
Take care.